Good evening and welcome to all of you. I welcome you with a warm welcome and namaste. I hope that all of you have been staying very healthy and in high spirits, and also you have been revising what we are going to discuss, what we have discussed. Let me just settle down with the audio video thing. I think now I'm settled. Okay. So, guys, I hope you have learned a lot of things in medicine as of now, and I'm pretty sure that you have revised all our discussions. And I also expect that last day's session for the MCQs was also wonderful. I received a lot of appreciations and messages from you. So, big thanks to all of you. My only motive for you to is give the informative, knowledge which can help you to gain the success. So again, today we are back with the another clinical case scenario session. Today we are going to discuss about what you call it as the clinical case scenarios, which I have particularly framed for all the people who are preparing for INICET NEET PG examination as well as for foreign medical graduate examination, right? Okay. So, guys, can you please show me your presence upon the audio, this one chat box about the audio video thing? Is everything okay? Can we start? I'm waiting for your replies. Hanji, can we start, guys? Thank you, Kelly, Swami. Thank you. Okay. So again, what we will do, we will have 1 minute time as we expect in the examination hall, right? And I will give you 1 minute time to look at your options, and then you have to reply me in the chat box that what is the best suitable option for the MCQ. So here goes with the first option, Hanji. So your time starts now. Okay. So let's read the question now. So what do we have in the option? I told you to read the last line first. So what is the most likely cause, first of all? And the options we are is Goodpasture syndrome, Church syndrome, IgA nephropathy, and Esterly. So let's read the question. 27-year-old male visits to your clinic with complaints of shortness of breath. So this shortness of breath is the important clinical feature, shortness of breath and cough with the cough with the blood streaks, right? So means this patient is having what beta? This patient is having hemoptysis. So first of all, this patient is having hemoptysis. So if someone is having cough with sputum or cough with the blood streaks, it is called as hemoptysis from the last 5 to 7 days. Right, his previous medical history is unremarkable. On examination, blood pressure is 180 millimeter of mercury and has bilateral edema over the legs. Right, so have bilateral edema over the legs. Chest X-ray shows pulmonary infiltrate. Sodium is okay. Normal range is 135 to 145 normal. Potassium range is 3.5 to 4.5, guys. So guys, I am giving you that this potassium is increased because the normal range is 3.5 to 4.5. Do remember this thing. Urine dipstick test shows RBCs, means this patient is having hematuria, very important, and proteins plus. Renal biopsy is suggestive of IgG deposition and crescentic glomerulonephritis. Hanji. So guys, can you please tell me what is the answer? Okay, so I appreciate the people who are giving me yes, Bhushan, it is pulmonary renal syndrome, or let's say the patient is having Goodpasture syndrome is going to be the answer. So what is the answer, beta? Goodpasture syndrome is going to be the answer, right? So the right answer is A, that is Goodpasture syndrome. Now let's discuss about Goodpasture syndrome. First of all, Goodpasture syndrome is a rare disease. Why I am saying that this is a rare disease? First of all, do understand that it happens approximately 1 in a per million case. 1 per million, right? This occurs in a 1 per million case. That's why it is the rare case. And basically, guys, it is characteristic of two involvement. One, there is a pulmonary involvement, plus there is a renal involvement. Renal involvement. So, as Bhushan has said, it is also called as pulmonary renal syndrome. So, pulmonary and renal involvement is there. So, in pulmonary, what happens, my dear? There are pulmonary hemorrhages. Basically, what happens? There is a cavity formation. क्या होना स्टार्ट हो जाता है बेटा? There is a cavity formation. Now understand the concept over here, that suppose this is an alveoli, below to this is a pulmonary, you know, vessel, and there is some kind of inflammation. Because of this inflammation, these vessels get weakened and the blood starts leaking down into the this one cavity. One thing, this is one mechanism. Second mechanism is this: as the size of the cavity increases, it touches that capillaries, and it makes the due to inflammation, it makes the pulmonary capillaries weaken, and due to this, again the blood starts leaking down into the capillaries. This blood mixes up with the sputum and comes in the form of hemoptysis. So first of all, there is infiltrates and there is cavity formation. So if you encounter this pulmonary infiltrates or cavity formation on the CT or on the X-rays, whatever the thing, along with this some renal pathology or some renal symptoms are given or signs are given, think of this Goodpasture syndrome. One thing, first of all, you have to keep this in mind. Second, my dear friend, this patient basically presents with what you call it as progressive renal failure, rapidly progressive renal failure. So they have a rapidly progressive renal failure. This is one very important thing in the MCQs. So I am repeating once again, there will be, shortness of breath, maybe there or may not be there, means it depends upon patient to patient, but generally yes, there is shortness of breath, then hemoptysis is there, right? Then progressive renal failure. They are not going to use this term rapidly progressive failure, they are just going to give you some clues about the progressive renal failure. Now how you are going to say that there is some renal pathology? Look at the BP. So this is BP, the diastolic BP is on a higher side, it is more than 90, it means some renal pathology is there, and some more bilateral edema over there. Why bilateral edema over there? Understand the concept. Here it is shown that there is 3 plus proteins. यहाँ पे देखो बेटा, ध्यान से देखो क्या लिखा हुआ है. There is proteins 3 plus. कितने? 3 plus. So what is the mechanism of the proteins? Particularly we talk about albumin to push the extracellular or the extravascular volume into the vessels from the third spaces, is tries to push the fluid back into the vessels. Now if the protein is on a lower side, what is going to happen? The intravascular volume is not the extravascular volume is not going to be maintained over there, so the patient will have now edema. So this patient is having edema, this thing. Got my point? And what do you call it as this is the characteristic finding, the crescentric glomerulonephritis. When we take the biopsy on histopathology, what we find there is a crescentic glomerulonephritis with the linear IgG deposits, with renal IgG deposits, right? Okay, ji. Now let's talk about some other, why the answer was not Churg-Strauss syndrome. We know that this Churg-Strauss syndrome has pulmonary component, but keep this in mind that Churg-Strauss syndrome is basically, what you got tends to be like an asthma-like disease. So there may be eosinophils increase, there may be wheezing, shortness of breath. So, but in the question there is no wheezing or what you call it as no wheezing or some asthma-like features are not present over here. Okay, ji. And then we have SLE. SLE do come with the what you call it as pulmonary symptoms. But in SLE, do remember, because of inflammation, there is pleuritis. So in SLE, there is what beta? Pleuritis. So there is no picture in the question or no history in the question which is telling us about pleuritis. That's why the answer is going to be the Goodpasture syndrome. Right? I hope you have enjoyed this MCQ. So let's move to the next question. Okay, so let's see what this question is asking from us. They are asking that which of the following is the less likely associated with this condition. So read this question very carefully. They are asking less likely, less likely. We do have options: papilledema, urinary incontinence, ataxic gait, frontal lobe dementia. Okay, so this question seems to be from neurology, right? Okay, G. And a 65-year-old female presents in OPD with complaints of gait abnormality from last 5 to 6 months. You suspect a normal pressure hydrocephalus. Which of the following is less likely associated with this condition? Yes, guys, your time starts now. Please answer. I'm waiting for your answers. Okay, so here the answer is going to be yes. A as papilla edema. This is the less likely because why it is the less likely? See, guys, the patient is you have suspected already a normal pressure hydrocephalus, right? Now, this normal hydrocephalus is basically misdiagnosed with what you call it as with either Parkinson's disease or let's say with or Alzheimer disease. But it is characterized by a triad. It is characterized by a triad. Now, what triad do we have? First of all, there can be dementia. There can be dementia, particularly that for frontal lobe dementia. Frontal lobe is mainly involved, right? Second is urinary incontinence. Urinary incontinence. Urinary incontinence. Third one is gait abnormality. Gait abnormality, right? So urinary incontinence is there, ataxic gait, and frontal lobe dementia is there, right? Okay, G. Now, why does this normal pressure hydrocephalus? Maybe you are getting it is. See, guys, it is least likely associated with this condition. Do remember this thing. Now, you see, normal pressure hydrocephalus basically occurs because of a defect of the absorption of the CSF, right? And it is mainly caused like in cases like in meningitis, trauma, particularly that of head injury, right? Subarachnoid hemorrhage, right? Malignancy, malignancy, or maybe after a neurosurgery, or maybe after a neurosurgery. These are some of the causes. Okay, Ji. So can we move further to the next question? Okay, Ji. Time's up. So let's read this question. Which of the following is the most appropriate for the prophylaxis of this condition? Now, guys, understand the concept. They are asking prophylaxis of this condition, and the options we do have is verapamil, propranolol, right, gabapentin, and rizatriptan. So from the options, we can say either there is some kind of migraine where we use these drugs, or maybe some kind of headache, right? So let's read this question carefully. A 30-year female visits to your OPD with complaints of intermittent headache. A very important history, beta. Intermittent headache from the last 5 to 6 months. From last 5 to 6 months, headache was sudden in onset, affects the right side of the head, and exaggerating pain around the right eye. Her family members have noticed that during the episode of the headache, her right eye becomes red and watery with drooping of the eyelid. This line is very, very important, with drooping of the eyelid. Okay. Once the headache resolves, all the symptoms disappear, all other investigations are normal. So, guys, I am asking you first of all, before you would answer me this question, I am asking what is this diagnosis of this? Is it migraine, or it is some other kind of headache? हाँ जी बेटा, कैन यू प्लीज टेल मी व्हाट इज दिस? क्या हो सकता है? इज इट ए माइग्रेन, और इज इट सम malingering, or whether it is this patient is having what, beta? Okay, Janani Ravi, it is, I really appreciate, but you have put a question mark. I don't know why you are not confident in writing the cluster headache. I really appreciate you have thought that it is a cluster headache. See, basically, guys, when you are going to do a clinical practice, headaches are the very common in your clinics, right, in routine practice. So do remember that headache is the most important topic, or migraine is the most important topic. Whatever the specialty you choose, headaches will be there. Not means your headache, but patients will come with the complaints of headache. Now, coming back to this question, the underlying condition here is cluster headache. First of all, cluster headache. It's not migraine, guys. It's not migraine. Teja Shivani, you might have found that propranolol we use in the prophylaxis of migraine. I do agree, but here I will just discuss in a while that what do we how we have to segregate between the cluster headache and between the migraine. Let's talk about the cluster headache. So basically, there is a distinct pattern of cluster headache. First of all, it can be unilateral. There is a history of sudden onset. So there is a history of sudden onset of headache, sudden onset of headache, right, with neurological disturbances, with neurological disturbances, right? So these are the two very important things. Now, why it is not migraine, guys? Understand the concept that in the case of migraine, what happens? First of all, do remember that it is most common in females. Most common in females, right? The characteristic feature of migraine that they aggravate on exposure to stress, right, light, sound. They are associated with nausea, vomiting. They are associated with what, beta? Nausea, vomiting, right? And they are associated with zigzag lines in front of the eyes, and what we call it as formification also. So there are other characteristic features also, right? So but these are some of the characteristic features where the cluster type of headache, they may or they may not come with the nausea, vomiting, but yes, this migraine definitely comes with nausea and vomiting, and there is a history of stress, light, sound, or there is a history of menses also. At that time, patient is going through the menses, right? So be very careful in reading that migraine part also. Coming back to this thing, so if we are going to talk about the treatment, first of all, let's talk about the treatment of cluster type of headache. So what is the treatment of a cluster type of headache? I am asking you treatment of cluster headache. Hanji, can you please tell me what is the treatment of cluster headache? What is the treatment of cluster headache? Yes, I am waiting for your replies. Suppose some patient has come into a acute attack. Some patient has came to you with an acute attack. So what treatment you are going to give, my dear friend? So first of all, you are going to give 100% oxygen. 100% oxygen you are going to give. You can give sumatriptan, or you can give rizatriptan. Any drug you can choose from the triptan, right? Then, my dear friend, you can also give NSAIDs. But if they ask you for, prophylaxis of cluster headache, then guys, particularly there has been so many studies that the calcium channel blockers like verapamil is going to be the answer. Verapamil is going to be the answer, but provided you should be very aware before starting the verapamil, you should check all the functions of the heart, or you should be you should keep this in mind that there are no contraindications of verapamil, like the patient does not have heart blocks, or the patient is not a case of left ventricular dysfunction. You should basically get an ECG done or a cardiac checkup done. There should not be atrial fibrillation or flutters, right, with the accessory conducting pathways. All you should need to keep this in mind. Apart from verapamil, you can also use methisergide. You can use methisergide. You can use ergotamine, right, or you can use high dose of corticosteroids, right. So this is the prophylaxis for a cluster type of headache. Among the options given, verapamil was in the option. So we are going to mark answer as what, beta? We are going to mark the answer as option number A, verapamil. Yeah, subcutaneous. Mubarak Khan, you are absolutely right that we are going to give subcutaneous sumatriptan. Yeah. Okay, subcutaneous we can give. Agree with your point. Right? Anything which is not clear in this question? चलो आगे चलते हैं. Haji, time's up, and I have received, approximately you have given me the right answer. So let's see what is in this question. What is the appropriate initial treatment? So options we have IV quinine, oral quinine, IV artesunate, oral atovaquone. So we know where these drugs are used. These are used in malaria cases, right? So let's see. See why I always tell you to read the the question last line in the starting and read the what you call it as options, because reading this options and reading the last line will definitely going to give you about the question, and reading the question your subconscious mind is going to take you towards the right answer. So guys, try to practice this multiple times. So let's go to the question. A 40-year-old man who works as a travel blogger, this history is the important. Travel blogger means this guy must be traveling from one place to another, from another to another, right? Presents to you with complaints of fever, headache, nausea, vomiting. He recently completed his official trip in forest of northeastern part of India. This is very important. Now, what the examiner is asking us that what is specific in the northeastern part of India? There are so many dense forests and rain is there. What is this, guys? There is rain is there. So if there is rain, it means there. And now you see, correlate with this, correlate with these options, rain and these options and malaria. Now where does this malaria occurs? Where there is a blockage of water, or there is a huge collection of dirty water. There the mosquito takes birth, and they breed over there, and then someone comes in contact with these mosquitoes and get malaria, and started feeling unwell during the last 3 days of the trip. He was not taking any prophylactical drug. Another important history: people who are travelers, or who are working in exposed environment, they are generally supposed to get some prophylactical drugs like anti-malarial drugs, drugs for yellow fever. All these drugs, I hope you have read this in medicine as well as in PSM also. So on examination, temperature is higher, 101.4 degree Fahrenheit, heart rate is 110 per minute. Investigation, HB is normal, WBC count is on a higher side, right? And then I think this is missed. Neutrophils are 76%. 76% as neutrophils, basically 40 to 60% are. So this one is the higher side. Platelet is also on a higher side. Normal range is 1.5 to 4.5 lakh. CRP is also increased. Urea is 33. Creatinine is normal. Blood film shows 7% parasitemia with Plasmodium falciparum. So Plasmodium falciparum. See guys, this question has completely given you to think that this is a sick patient. Why I am telling you this is a sick patient? Look at this over here. He is having infective etiology. One thing, he is going to be in a sepsis. CRP is highly raised. If the CRP is raised more than 10, guys, expect a severe kind of sepsis. If it is more than 10, expect a severe kind of sepsis, right? So some more, the patient's platelet counts, because of inflammation, platelet counts has also increased. There are 2 3 things that is important and telling us about the sepsis and what is the source of the sepsis, what is the cause of the sepsis. This malaria is there. Guys, do understand this thing, that in severe cases of malaria, in severe cases of malaria, WHO has clearly recommended the use of IV artesunate. IV artesunate needs to be given. See guys, quinine is generally given for routine cases of malaria. People who are not so severe sick or who are mildly sick, we can give oral quinine, because it takes a long time to occur and it has a prolonged course. That's why usually and it is also prescribed along with doxycycline. But here in reading this question, you can assess this patient is a severe case or a serious case of malaria. That's why we are going to give artesunate. Okay, Ji. And this intravenous treatment should be given for at least 24 hours, minimum of 24 hours. Can we move to the next question? Okay, Ji. Okay, time's up. Please answer. Let's read the question. Apart from anti-rabies treatment, what is the most appropriate? So means anti-rabies, there must be a history of some, animal bite, particularly that of dog bite. So let's read the question. Metronidazole and doxycycline, ciprofloxacin, co-amoxiclav, and erythromycin. A year old school, I don't know, let's say it is a 16-year-old schoolboy present to emergency after a dog bite on his left hand. He is hemodynamically stable. There are so many misprintings, guys. I apologize for the misprinting. Okay. On examination, you find that there are 5 1 centimeter wounds. So there are multiple and enough wounds on the thinner aspect. So this is the thinner aspect, right, of the left hand. Apart from anti-rabies treatment, what is the most appropriate? What is the most appropriate treatment apart from the anti-rabies? So one thing is very clear: the examiner has given an anti-rabies. So we need to think apart from anti-rabies. Why we need to think? Guys, understand the concept over here, that in any case of dog bite, there are chances that 15 to 20% of the people, they may develop some kind of infection in the coming days, right? So they may get infected due to exposure of the bites, or because of the wound, right? So, and guys, you have to always rule out any muscular or any nerve injury in a case of dog bite, and then you have to administer tetanus toxoid in regular injection, TT, you have to administer along with anti rabies, this thing, right? And understand the concept that if I am telling you guys that there are 15 to 20% chances of the infections, my question to you is this: what are the organisms which are responsible to cause some kind of infection? What are the organisms? So if we know the organisms, then we are going to choose the right answer. So I am waiting for you over here for 1 minute, guys. Please tell me, guys, that what is the organism which can cause infections in a case of a animal bite or in a case of rabies? Hanji. Okay. So guys, do remember this thing, that Staph aureus, Pasturella. Yeah, I agree. Staph aureus, Pasturella, right? Then Streptococcus. Then we have Corynebacterium, Corynebacterium, right? These are some of the common organisms which are responsible to cause infections, right? Now answer, you have given me C. Okay. So I do agree with your point. The answer is going to be the C. So this is the preferred drug to give in a case of augmentin, or what you call it is the drug name. I'm not promoting the drug, but generally it is widely available. That's why I'm telling you it is clavulanic acid plus amoxicillin by the name of augmentin. I am not promoting. I am not getting anything out of, but I'm just telling you because when you're going to do clinical practice, it is widely freely available. That's why co-amoxicillin and amoxicillin plus clavulanic acid is going to be the first line drug in a case of a dog bite. If the patient is allergic to penicillin, first of all, also do remember this thing. If the patient is allergic to penicillin, then obviously you are going to give doxycycline, right? Plus minus depending upon the doctor and depending upon the degree of or the severity of the wound, you can give metronidazole. You can give metronidazole, right? Expectant, don't give this in pregnant ladies, right, and children. And other antimicrobial drugs can be used like erythromycin. You can use you can use clindamycin, or you also can use ceftriaxone. You can also use ceftriaxone, right? Beta, Midoriya pseudomonas, staph pseudomonas. Okay, there are two questions. First question is I am replying to Midoriya. Sir, can pseudomonas or Clostridium infection occurs? Less likely, beta. Less likely. Then Iqbal, you are asking, sir, 1 centimeter wound means it's severe wound, needs to clean and ARV and VTT. Yes, obviously, my dear friend, 1 centimeter is a severe wound. Is a severe wound. And here, see, right in the question, there are 5 wounds, 1 centimeter. 1 centimeter कितना हो गया? ये इतना लगभग हो गया 1 centimeter, right? और इस तरह के 5. So it's going to be a severe wound, right? Let's jump to the next question now. Time's up, guys. हाँ जी. Okay, so let's discuss this question. What is the most likely cause? Bacillus cereus, E. coli, Campylobacter jejuni, and Staph aureus. These are the options. Okay, so we know this thing that what do they cause? All these, if they are common in GI, gastrointestinal diseases, they cause, right? So let's read this question. So our examiner is going to take us in the GI system now. Okay, a 35-year-old patient presents to ER with at approximately 10 p.m. department. Guys, there is a misprinting. ER department. Here it should be written ER. Okay. A 35-year-old patient present to ER department approximately at 10 p.m. with multiple episodes of vomiting. He reports that he had chapati and dal and cheese curry in dinner at approx 9 p.m. Okay, but in the lunch he had reheated fried rices which he earlier brought from the nearby restaurant last night. So this history is the important history that he brought last night. ये उसने जो पिछली रात को आया था वो खाना कब खाया, गरम करके फिर से he reheated that and then he had in the afternoon. So what is the most likely cause? Yes, LMS biochem classes incubation period is 6 to 8 hours. So can you please tell me that what is your A? A is your answer. Okay. I agree that the answer is going to be the A1, Bacillus cereus. Now, why it is not going to be, Campylobacter jejuni? Why it is not going to be E. coli? Why it is not going to be the Staph aureus? As you know, this guy LMS has tell us incubation period is the important feature for any organism to cause the GI symptoms like nausea, vomiting, or diarrhea, right? So we should be very aware of this thing. Now let's talk about the Bacillus cereus first. Bacillus cereus, right? Clinical features and incubation. Let me write over here. I will make a table and then I will explain you. I think that's a better manner. So here is the pathogen, here is the pathogen, here is the incubation period, here are our clinical features. Here are our clinical feature. So the first very important pathogen we will discuss obviously is going to Bacillus. Guys, this is of two types. This is of two types, first of all, right? First of all, if it is causing nausea and vomiting, clinical feature, nausea and vomiting, clinical feature, nausea and vomiting. Then, my dear friend, for nausea and vomiting, the incubation period is going to be 1 to 6 hours. 1 to 6 hours is going to be the incubation period. Now, in the question itself, do remember this thing, 10 o'clock the patient is presenting, but in the lunch, see, read the question carefully, guys. कहाँ गया हमारा question? Right? In the lunch, कहाँ है? Last night का इसने क्या खाया था? Reheated. And the patient is presenting, see, we do lunch between 1 to 3 p.m. So expecting this thing that he must have done approximately at 2 p.m. or somewhere like this thing. General population does the lunch like this thing. Right now it's been 8 hours. It's been 8 hours. Right. So this thing, 6 to 8 hours nausea vomiting can start developing. Right. Patient can have diarrhea. Patient can have diarrhea and I have written over here. Patient can have another clinical feature as diarrhea, and the incubation period to develop diarrhea is approximately 6 to 14 hours. So here, my dear friends, the average range is 8 hours where the patient was developing the symptoms. Where the patient was developing the symptoms. And do remember this characteristic feature, this nausea vomiting develops because most commonly because of, I am writing over here, most commonly because of noodles and reheated rice. So this is the characteristic feature, right? Whereas other options like, what are the options we do have? Okay, E. coli, Campylobacter jejuni. E. coli incubation period is approximately 12 to 48 hours. Incubation period कितना है बेटा? 12 to 14 hours, right? And what are the clinical feature? Patient have abdominal cramps. Abdominal cramps. The most important feature, patient can have nausea and patient can have watery diarrhea. Patient can have what? Watery diarrhea. Right? Then guys, apart from E. coli, Campylobacter jejuni, the incubation period is 48 to 72 hours approximately. Right? This Campylobacter jejuni characteristic feature is basically because of the canned food, right? So there must be some history of canned food, or the patient will present like flu-like symptoms. Patient can have abdominal pain, or let's say fever, right? Myalgia, right? Patient can have abdominal pain, cramps, right? Abdominal pain, cramps, and later patient can have diarrhea. Later patient can have diarrhea. We are left with the last option, that is Staph aureus. Staph aureus incubation period is 1 to 6 hours, right? And here patient have severe vomiting. Severe vomiting, guys. So this is the important, organisms which can cause the GI symptoms. So always keep all these organisms literature ready upon your fingertips. These are the most likely questions to be asked, right? Okay, quickly revise this, then we proceed further. Chalo, let's move to the next question. Yeah, GVS can occur, guys. GVS can occur after Campylobacter jejuni. Yes, LMS. Okay, time's up. Let's read the question. What is the most appropriate next step in the management? And what are the options we do have? We do have balloon dilatation, nifedipine, endoscopic botulinum toxin injection, and Hiller myotomy. Okay. So we know this thing. Where do we use this thing? We use in some, guys, in the problems of the esophagus. So let's read this question now. 55-year-old male patient visits you with history of weight loss. Important one, weight loss. Difficulty in swallowing and swelling for both solids and liquids. The important history. So there is a dysphagia for both the solids and the liquids from the last 4 to 5 months. He also complains of cough, which is more in the night. So, guys, this is also the important history, right? More in the night time. Very important history, right? So, guys, do remember this thing more in the night time. So, in a case of GI symptoms, there must be some regurgitation, right? That's why, because regurgitation can cause cough, and one of the most common cause of cough is also GERD, gastroesophageal reflux disease, where regurgitation occurs, right? Do remember this thing. He is a reformed smoker, which he left smoking since last 5 years. So, guys, 5 years means ki 50 at the age of approximately he has left smoking, right? We don't know how heavy he smoker was this thing, but let's presume that he was having 4 5 cigarettes or maybe one cigarette a day at age of 50 he has left. So maybe he had a little kind of COPD. I'm not saying telling you that this question is telling you reform smoker है तो हो सकता है नहीं भी हो सकता है, but proceeding to the question. On variums mellow, dilatation of the proximal esophagus with tapering of distal esophagus, very important history, dilatation with tapping of distal esophagus. Gastroscopy is unremarkable. What is the most appropriate next step in the management? Those, I would like to know what is this. Yes, LMS, you have given me a right answer. Anybody agrees with this answer? I hope you agree with this answer. So this patient is basically having achalasia. So let me take on the note. So this patient is basically having what beta? This patient is having achalasia, cardia, achalasia, cardia. Now why this patient is having achalasia cardia? Now what basically this achalasia cardia? Achalasia cardia is a dysmotility which is characterized by increase in lower esophageal sphincter tone, right, and which reduces the lower esophageal sphincter relaxation, esophageal relaxation is reduced, and it there is or decreases, or maybe there is absent peristalsis. Characteristic feature of this thing is that this patient basically have dysphagia to both solids and liquids, guys, right? This is the characteristic feature, that this patient have dysphagia to both solids and liquids. Apart from this dysphagia, another clinical features or the symptoms include like heartburns, the important one, heartburns, right? Regurgitation of food, and because of regurgitation, guys, there is cough also. So cough, most common mechanism is regurgitation. So do remember this thing, guys, the important one, the important thumb, right? And when the patient lies down, there is more regurgitation, and all the food content, they come upon to this level, right, at the vocal cords level, and then it start entering into the trachea. There are chances of micro aspirations over there, and this larynx and pharynx get irritated and patients start having cough. This particularly occurs in supine position or in a lying position, this one, and there is a risk of pneumonia also, right, and weight loss because of chronic infections. Now you see in the question it is already classified that the barium meal is necessary, and it is showing dilatation of the proximal esophagus, means narrowing or tapering of the distal esophagus. And what kind of characteristic feature we see over here? Bikes, oh sorry, not bike, what you call it as birds beak appearance. Words beak appearance. Yeah, LMS you said right. Cardiac achalasia, words beak appearance is seen. Now you see all the options in the questions in the question are potentially treatment options. They are equally good, potentially good, but drug treatment with nitrate and calcium, nifedipine, here it is given, right? I'm talking about the second option. They are the least effective. Studies have shown that they show the least effective, right? So because of this, I am taking this out first of all, right? Now you see Heller myotomy. Let's talk about Heller myotomy. It can be taken surgical measurement, or the operation can be taken, but we still have time. We still, it is not the next step or next step of management. First, let's go with, what you call it as balloon dilatation, because, endoscopic therapy is preferred initially, but symptoms reoccurrence is most common with, this thing, right, as compared to endoscopic botulinum toxin injection, right? Balloon dilatation has shown better results, right? Because I was explaining you that endoscopic therapy is generally preferred initially, but there are chances of reoccurrence. Because the chances of reoccurrence are occurring, that's why the balloon dilatation does not, is less, what you call it, is less, they have less, side effects, like reoccurrence is less than endoscoping botulinum toxins. That's why the balloon dilatation is better option than endoscoping botulinum toxin injections. So guys, do remember this thing. First, you have to give the balloon dilatation. If this does not work, then obviously you are going to go endoscoping botulinum toxins. If there is reoccurrence, then obviously you are going to go for Hiller myotomy. That's why the answer is going to be you. The balloon dilatation is going to be the answer. Okay. Let's move to the question number next. Okay. So time's up. Which of the following is the most initial test? So options we have is dexamethasone suppression test, 24-hour urinary cortisol, abdomen pelvic ultrasound, LH and FSH. Okay, ji. So where we all, in which kind of disease, endocrine problem, we do all these kind of tests where there is a problem with the either with the pituitary or with the adrenal gland. This thing is very clear to us. Okay. Either with the pituitary problem or with the, what you call it as with the adrenal problems. Okay. So let's see what this question is saying. 18-year-old female visits her family physician with history of weight gain, increased growth of facial hair, and amenorrhea. Her blood pressure is 150/86 millimeter of mercury. Which of the following is the most initial test? Okay, guys. Guys, people who have given me A answer, can you please tell me why you have chosen A answer? People who have given C as the answer, or let's say B as the answer, first of all, can you please explain me why you have chosen A as the answer? What is the diagnosis of this thing? Anji, what is the diagnosis of this thing? So, guys, someone has said right. Kahan gaya? LMS, you have said right. Obviously, this patient is having Cushing syndrome. This patient is having Cushing syndrome. Now, once I have told you Cushing syndrome is the diagnosis over here, would you like to change your answer now? Anybody would like to change your answer? We know what are the, symptoms of Cushing syndrome. What are the symptoms of Cushing syndrome? Anji. So, Asik Iqbal sir, first we need to see the uterus present or not, then hormonal. Look at the explanation. Cushing syndrome, guys, is basically what? It is the excess intake or endogenous production of the steroids. Agree with my point? What are the side effects of the steroids are going to be the clinical feature of the Cushing syndrome. This you have to make it a thumb rule. Buffalo neck, hair growth, everything is there. Right now, you itself you are saying, sir, Iqbal sir, you are saying hair growth. So in the question, here you see increased growth of facial hair. Steroid side effect, either it is endogenous or exogenous intakes, weight gain is going to be the side effect. Amenorrhea, it is going to be the side effect. Infertility is going to the, because of amenorrhea, infertility, and in males it can also cause this one infertility also, right? Then buffalo hump, central obesity, bruising, acne, these all are the side effects, right? So I'm just telling you what are the clinical features of Cushing's, or you can also remember as the side effect of the steroids. So the first very side effect is weight gain. One thing is weight gain. Patient can have hypertension, bruising, right? Acne. Patient can have hirsutism, right? Patient can have amenorrhea. Patient can have amenorrhea. Patient can have proximal weakness. Proximal weakness. Central obesity. Central obesity, right? Papery skin. Papery skin. Patient can have also depression. Right. So these are all the clinical features of what you call it as Cushing syndrome, right? And do remember this thing, guys, that what happens in Cushing syndrome, both dexamethasone, this dexamethasone suppression test, and 24-hour urinary cortisol are used as the initial test. Both are used as the initial test. Both are used as the initial test, but suppression test, this suppression test is more sensitive. This is more sensitive. It is more sensitive. That's why the answer is going to be there, right? It is going to be the answer. Okay. Yeah, hypokalemia, metabolic alkalosis, all are the side effects. Purple stria, abdomen. I do agree with your point, right? Okay. So let's proceed to the next, this one, MCQ. Time's up, guys. What is the most likely cause of infertility? Cushing syndrome, Kalman syndrome, Cushing, I just told you, Kalman syndrome, Klinefelter syndrome, hypogonadotropic hypogonadism. Right? These are some of the options. A 30-year-old man and his wife present to you because of not getting pregnant despite of unprotected intercourse during last 2 years. So this history is very important. We call it as infertility or sterility. If someone is not getting pregnant despite of unprotected intercourse within a year, so within a 1 year of time. But here, how much is the time? it is already 2 years, so more than a year. On examination, husband is tall, gynecomastia, and have scanty pubic hair. So who is having the problem? Not the female, but the male partner is having a female. So what is the answer, guys? The answer is going to be the Klinefelter syndrome. I think this is a very easy question. So this Klinefelter syndrome, the prevalence is approximately 1 in what you call it as 500 to 1000 males, right? Male, in males I'm talking about, right? And it is caused by basically X by genotype, another, right? Extra X is there, or XXY is there, right? So features include basically tall stature, right? Infertility. So tall stature, infertility, right? Patient have small firm testis. Patient have beta small firm testis. Gynecomastia. Gynecomastia is there, right? And the another feature is poor character, what you call it as secondary sexual characteristic development. Poor development of secondary sexual characters, right? These all are the features, right? So can we proceed to the next answer, next question? चलें आगे. ओके जी. So you are getting confused between C, SLE and B. हाँ जी. Time's up. Let's read this question. Nuclear, anti-nuclear antibody, not antibody. It is antibody pattern is most common associated with which condition? Crest, scleroderma, SLE, or Jogren? हाँ जी. Anyone else want to participate? Crested limited sclerosis, ANA for SLE. Okay. Crest is seen in, okay. See guys, what happens? This anti-nuclear antibody is a group of, it's a basically heterogeneous group of antibodies. They are seen in CREST syndrome. CREST means calcinosis, Reynolds phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. Right? They can be seen there. Scleroderma in SLE, systemic lupus erythematosus. They can be seen in Jogren syndromes. Right? They can be seen in mixed connective tissue disorder. So each disease has its own specific kind of anti-nuclear antibodies. But particularly if they are asking, nuclear anti-nuclear antibodies, then my dear friend, it is going to be seen in scleroderma. Let's quickly revise about these antibodies. First of all, if they are asking that, as I just told you, that nuclear is, it is associated with, Hanji, it is associated with scleroderma. This one is associated with scleroderma. Then we do have what you call it as centromere. We do have centromere. This centromere, Hanji, my question is to you, is this centromere is associated with what? Centromere is associated with, yes, I am waiting for your replies, guys. बताइए सेंट्रोमियर किससे एसोसिएटेड होता है? Centromere is associated with crest, right? Then homogeneous antinuclear antibodies, they are associated with SLE, right? If they ask what you call it speckled, then they are associated with, first of all, mixed connective tissue disorders, right? They are associated with SLE, they are associated with Sjogren syndrome, SS, or they are associated with polymyositis, right? Polymyositis. If you want to need, what you got, if you want to be more specific about these, specific diagnostic, then antibodies needs to be, what you call it, extravasal nuclear antigens, ENA, what we call it as ENA, extravasal nuclear antigens. And for that, I am just, see guys, I am going to ask you, you have to participate, that I am going to write you the anti-nuclear antibodies and you have to tell me they are associated with. So guys, let's quickly revise. This is the important one thing. The basic one I am asking, anti-double stranded DNA. Anti-double stranded DNA. They are associated with what, beta? Hanji, can you please tell me? Second question is anti-Rho, anti-La. They are associated with what, beta? Anti-Smith, SM is Smith. They are associated with what, beta? Right? Anti-Jo 1, anti-SCL 70. चलो इतने करते हैं पहले. बताइए, एंटी डबल स्टैंडर्ड डीएनए इज एसोसिएटेड विद, yes, you have written me right, it is associated with SLE. Anti-Rho, they are associated with Sjogren syndrome. SS I am writing as the Sjogren syndrome, right? Anti-Law also associated with, Sjogren syndrome. Anti-Smith is associated with SLE, but most commonly 70% of the patients, they are associated with anti-double stranded DNA bodies, anti-Smith antibodies. They are approximately 70% of the patients, they come with anti-Smith antibodies. Anti-Jo 1, they are associated with polymyositis. Polymyositis, right? Anti-SCL 70 is associated with scleroderma. It is associated with scleroderma. Apart from this, we do have, anti-TTG, anti-TTG, tissue transglutaminase. Where do you see this? Anti-TTG. कहाँ पे देखते हैं बेटा? Anti-TTG is seen in celiac diseases. It is seen in celiac diseases. Very good, LMS. Very good. Okay, let me ask you one more. Anti-mitochondrial. Anti-mitochondrial. Where do you see this? Anti-mitochondrial? Hanji. Very good. It is seen in primary biliary cholangitis. It is seen in primary biliary cholangitis. So guys, there are many more, but these are some of the important I have quickly revised. So guys, when you are going to revise this thing, make it is the important ones and must know one, because it has been asked multiple times either in INECT, NEET PG, or even in FMG. This is one of the favorite questions of the examiner. They can come you as a one-liner. They can frame out a story and you can ask this thing. So this is the important table you have to remember, guys. Okay. Can we proceed to the next question? Guys, you have to excuse me, my I was not able to see your chat. My phone got switched off, so just give me a moment. Let me start the YouTube session upon my laptop also. Just give me a moment. Please try to sort out this question. Just give me a moment, guys. I really appreciate your patience, guys. Here was there some technical problem. We sorted it out. Okay, so metabolic acidosis with normal anion gap acid with normal gap is seen in diabetic ketoacidosis, renal tubular acidosis, salicylate poisoning, acute renal failure. I think this is a very simple answer, and you have given me some of you have given me the right answer. So, guys, what is the answer? Hanji, what is the answer? So here the answer is going to be the renal tubular acidosis. Particularly if they ask you what kind of renal tubular acidosis is associated with normal anion gap metabolic acidosis, then guys do remember this thing that type 1, 2 and 4 it is associated with, right? So what are the causes? What are the causes? Let's discuss about the causes of the normal anion gap acidosis. The mnemonic is hard up. What is the mnemonic? Hard up. Hard up, right? First of all, it is yes, Hanji. H per it is hyperelimination. It is hyperelimination of TPN, right? A is acetazolamide. A is acetazolamide, right? Then R is renal tubular acidosis 1, 2 and 4. D is diarrhea. D is diarrhea. U is uretro renal uretrointestinal fistula. Uretrointestinal fistula, right? And P is pancreatic fistula. Pancreatic fistula, right? So these are the causes of basically normal anion gap metabolic acidosis. Guys, this is important. You have to also remember what are the causes of low anion gap acidosis or high anion gap acidosis. So put a star mark while you have to revise. Please revise this thing, right? Okay, now let's proceed to the next question. Haji guys, let's read the question now. I'm zooming it and I am expecting the right answers. Okay, Deepak Kumar Singh, your answer is right. The answer is going to be the hemolytic anemia. Let's say, what is the most likely cause? Urine lysis is negative for bilirubin. A 40-year-old patient present to you because of jaundice. Simple. Because of jaundice. Now, guys, what is jaundice? Hanji, what is jaundice, guys? Now, jaundice, we know it's a yellowish discoloration of the skin or the sclera, and it is caused because of the elevated levels of bilirubin. So it is caused by the elevated level of the bilirubin. Now, how does this bilirubin is formed? So basically, bilirubin, we know very simple, physiology, that it is formed because of the breakdown of the hemoglobin to form unconjugated bilirubin. To form unconjugated bilirubin, right? Right, so we know this thing that there is a breakdown. So if there is a breakdown, my dear friend, what is the answer going to be? Hemolytic lysis, means टूट रहा है वहां पे, hemolytic anemia. Okay ji, let's read this question carefully. This was a pretty simple question. Now guys, let's read this question. You have 1 minute time.